Hi, everyone. Welcome to the CanVector National Thrombosis Seminar, the first lecture of the 2022-2023 series. I'm Camille Simard. I'm a general internist and obstetric medicine physician in Montreal, and I will be your host today. The CanVector National Thrombosis Seminars are monthly seminars that will be hosted live throughout the academic year and will feature state-of-the-art thrombosis and VTE lectures presented by both Canadian and international experts. The video recordings of these seminars will be available online at canvector.ca. And just a reminder that these seminars are approved as Section 1 activities as defined by the Royal College. This is our 2022-2023 Planning Committee, and our chair is Dr. Tzu-Fei Wang. So today's presentation, I'm so honored to be presenting our speaker, Dr. Saskia Middeldorp, who will be talking about prevention of VTE in pregnancy. Are we making progress? I will briefly introduce our speaker today. Saskia Middeldorp is a professor of medicine and head of the Department of Internal Medicine of the Radboud University Medical Center in Nijmegen, the Netherlands. Prior to her transfer there in January 2021, she has been a professor of medicine at Amsterdam University Medical Center for over 10 years, leading the clinical thrombosis and hemostasis research lines of the Department of Vascular Medicine. Her present research focuses on several aspects of hereditary and acquired thrombophilia, women's issues in thrombosis and hemostasis, and the clinical evolution of new anticoagulants. She is the principal investigator of practice-changing trials such as the investigator-initiated ALIFE, ALIFE2, and the high-low randomized control trials. Saskia Middeldorp is an elected council member of ISTH. She is the immediate past chair of the Invent VTE Network, an associate editor of the Journal of Thrombosis and Hemostasis, and an editorial board member of Blood. In December 2016, she held the Ham Wasserman Lecture and received the accompanying award in recognition of pioneering work in inherited thrombophilia at the annual ASH meeting in San Diego. In October 2021, she received the Heymans Vanderburg Penning, a once per 5-year honorary distinction of the Netherlands Internal Medicine Society for her achievement in terms of science, education, governance, and being a role model for young internists. She is a member of the Venous Thrombosis Guideline Coordination Panel and chair of the Thrombophilia chapter of ASH. She has co-authored the pregnancy chapter of the ASH Pregnancy Guidelines in 2018, as well as the 9th edition of the Anti-Thrombotic Guidelines of the ACCP in 2012. Saskia currently supervises 10 PhD students and has co-authored over 470 peer-reviewed papers and several book chapters, as well as review manuscripts for international scientific journal. So we're extremely honored to have Saskia present today. These are the learning objectives for her talk. And just a reminder before I let Saskia present that we're looking forward to your questions, and there will be a 15-minute Q&A period at the end of the presentation. So please submit your questions at any time throughout the talk in the Q&A box, and I will be monitoring them. So with that, I let Saskia present her slides.
Thank you so much for this introduction. And it's really my pleasure to present my favorite topic, VTE in pregnancy and the prevention thereof, for such a great audience, because I do really think that the Canadians are on top of the world if it comes to thrombosis. And I'm really pleased to be able to share also not only the top line results, but some of the insights of the high-low study as well. These are my disclosures, and I always say that I don't buy shoes of these disclosures or of these fees. They're all transferred to my institution and used for investigator-initiated research. So I'm going to talk about the following: a few facts about pregnancy and venous thromboembolism and anticoagulants in this population that is often called also by myself a special population. And then, of course, I will dive deep into the results of the high-low study. So this is what it's all about. This is my main, let's say, internal driver. On the left here, you see a young girl that I've never met myself, but I met her parents and her sister after Laura died of pulmonary embolism, after she had been denied proper diagnostics simply because she was 17 years old. The diagnosis of pulmonary embolism was not considered. In the middle, we all know Serena Williams, who I think is a great example of pregnancy-related VTE, or I should say prevention of pregnancy-related VTE. And of course, Stop the Clot also, the Stop the Clot awareness campaign also runs in the Netherlands. And this is what it's all about. So we say special populations, but let us not forget that women are half of our population and that many women do get pregnant at least once in their lives. So let us consider which women are at a high risk for pregnancy-related venous thromboembolism. I've listed it here. Women with a personal history of VTE are going to be the topic of today's talk, because that is the strongest risk factor of getting a clot in pregnancy or shortly thereafter. But of course, also women with known thromophilias and unknown thromophilias, or those with a strong family history, with or without a known thromophilia, are women who are at increased risks. And then I don't even consider, let's say, the population types of risk factors, such as obesity, complicated pregnancies with immobilization or preeclampsia, postpartum hemorrhage, and so on. And the other thing that I would like, and I don't have time to go into all these details today, but if we consider thrombosis prophylaxis, what we do need is to know what the absolute risk is during pregnancy or in the postpartum period, in order to decide whether the burden of treatment actually is in balance with the assumed benefits of giving pharmacological prophylaxis. And then the other thing is, so if a woman is at a high enough risk to also get prophylaxis during pregnancy, then we need to consider what agents, which dose, should we monitor or not, and how do we handle delivery. So this is a slide from the ASH pregnancy chapter that was written by, or chaired by Shannon Bates. And you can see that it's not that difficult. If you look at anticoagulants in pregnancy, we basically have the choice of heparin and heparin. There is a preference of low molecular weight heparin over unfractionated heparin for maternal safety and also convenience reasons. And then there's fondaparinux, the pentasaccharide, that is listed as not preferred because it is reported to cross the placenta in small amounts. And clinical experience with fondaparinux in pregnant women is limited. But I must say that if all else fails, that I do sometimes use fondaparinux in pregnant women. Vitamin K antagonists are known to cross the placenta. They have the potential for warfarin embryopathy, but also if it is given in the second trimester, there is an increased risk of neurodevelopmental deficits. And for the indication of venous thrombosis, vitamin K antagonists should be avoided. This is something different from the mechanical heart valves, but I'm not talking about these women. And then direct oral anticoagulants should not be used in women who are pregnant or breastfeeding. Now, so if it's heparin and heparin, then what are the side effects? And these are 3 patients of mine. Let us first consider that the women need daily injections, and 20 to 40% of the women do experience skin reactions to the injection site, which is mainly type 4 delayed type hypersensitivity, but also hematomas around the injection site, some of which are quite large and can be painful, particularly if clothes are also around the belly. And unfortunately, very rarely you can see a type 1 allergy, as is shown in the lower right picture. Clearly, if you give anticoagulants, we're always a bit concerned about increasing the risk of bleeding, something that raises a lot of concern in women who are pregnant antepartum, but obviously around delivery, with postpartum hemorrhage being an important problem, of course, is also something to consider. Then, of course, there are timelines to be respected for neuraxial anesthesia of 12 hours with low dose and 24 hours with higher doses of low molecular weight heparin. And the risk of heparin-induced thrombocytopenia, particularly with low molecular weight heparin, is very, very small. So that is not a real problem. Now, given that we are prescribing to women a long-term low molecular weight heparin, in long-term, I mean the entire pregnancy, including the postpartum period, altogether, it is easily a 10-month period. Then, of course, it would be nice to know we're doing the right thing. And if we consider dosing of low molecular weight heparin, there is wide practice variation. And I noticed when I moved, this is much longer than 10 years ago, but when I moved as a young internist from Amsterdam to Leiden, we had that's only 30 kilometers or 35 kilometers. It's a very small country where I live. Nevertheless, in Amsterdam, we were using therapeutic dose low molecular weight heparin at that time. And we're speaking about 2006 or something. Whereas in Leiden, they used the low dose prophylaxis in women who are pregnant or postpartum. And I noticed on my first outpatient clinic, a woman who had a postpartum pulmonary embolism despite getting her prophylaxis. And when I discussed this with my new colleagues in Leiden, they said, well, we never see this. And together with the Janine Roeters van Lennep, we went back to find all the women who had been prescribed this low dose, and we found an up to 8% risk of recurrent VTE in high-risk women, mainly those with a history of VTE. And that sort of fueled my interest of getting this cleared up. So what do we know about low molecular weight heparin? Well, we don't even know much about low molecular weight heparin dosing differences for prophylaxis in a non-pregnant population. But also for the VTE guidelines of ASH, the research agenda shows that more data are required regarding optimal intensity of low molecular weight heparin prophylaxis in the antepartum and postpartum setting. And now I'm going immediately to fast forward last weekend, where we had the pleasure of having the high-low study that I was able to present in London last July on the ISTH conference, was published in the Lancet last weekend. And I'm really thrilled to share with you the excitement after a decade of work that we completed this study, that it was done, and that we did find some answers. And I'm really curious also to see, of course, what guidelines panels, how they will weigh the evidence that has come forward from the high-low study, which was an open label, multi-center randomized controlled trial. So if we look at what the guidelines of thrombosis prophylaxis in pregnant women with a history of VTE say, then I think there is absolute consensus about this flow diagram. So if a woman has a history of venous thrombosis and no chronic anticoagulation, then most of these women either had an unprovoked, but I think really most of the women have had a temporary hormonal risk factor with their first venous thromboembolism. And according to the guidelines, these women need antepartum thrombosis prophylaxis during the entire pregnancy, and of course then also extended to postpartum for 6 weeks. And only the few women who had a temporary non-hormonal risk factor and no other risk factors only need postpartum prophylaxis. So looking at this, it basically means that virtually all women with a history of VTE who are not on continuous anticoagulation need antepartum thrombosis prophylaxis. And what we know also from many observational studies is that the thrombosis risk is more or less similar and is there immediately in the first trimester, meaning that we need to start thrombosis prophylaxis as early as possible. Now, As I already mentioned, the dosing of low molecular weight heparin in pregnancy is unknown. But what we do know is that many things change in a woman's body once she is pregnant. The circulatory volume increases and the cardiac output, of course, then increases. The glomerular filtration rate of the kidneys increases. And we do know that low molecular weight heparins and heparins are being cleared through the kidneys. And of course, women do gain weight during pregnancy. So we really don't know what is happening to low molecular weight heparin, although obviously there have been observational studies looking at anti-10A levels, for instance, showing that these are lower in pregnant women. Nevertheless, generally, also in the guidelines that I was part of, we extrapolate the efficacy of low molecular weight heparin thrombosis prophylaxis from populations who use low molecular weight heparin for a prolonged period of time, for instance, after total knee replacement. But clearly, these patients are much older, have lower filtration rates of the kidneys. And I thought this was really unbearable. So we're prescribing 10 months of needles, but we don't know what's right. And that is, I think, a very strong picture of one of the high-low participants who actually put all the syringes, the empty syringes around her beautiful baby after having participated in high-low, just to show us what it means to inject this. And then we better get it right. So the high-low study was designed 10 years ago as an investigator-initiated international open-label RCT. Actually, it was first designed nationally, but we gained a lot of international traction and we're very, very happy. And without our colleagues across the borders of our small country, this would never have succeeded. And at the end of the day, we ended up with 70 centers in 9 countries. As I said, open label, but what we did do is install a central independent adjudication committee. The inclusion criteria were women with a history of VTE, either unprovoked or related to hormonal risk factors who were off chronic anticoagulation. And they needed to be randomized prior to 14 weeks of gestational age. The low dose, low molecular weight heparin was a common prophylactic dose, and the intermediate dose was a once daily dose that was roughly half therapeutic. Then we simply followed women, prospectively, of course, up till delivery, up to 6 weeks postpartum for the primary endpoints and up to 3 months postpartum for the secondary endpoints. And the low molecular weight heparin was prescribed until 6 weeks postpartum. The efficacy outcomes were symptomatic VTE up to 6 weeks postpartum, and this included deep vein thrombosis at various sites, pulmonary embolism, and unusual site thrombosis like a cerebral vein thrombosis. And then we had secondary endpoints that were the 3 components of the primary outcome. But, and I think this is important, we also a priori defined a secondary outcome that included superficial thrombophlebitis. And the reason to do so is that we do know that this occurs quite frequently in women who are pregnant and generally lead to an increase of of low molecular weight heparin dose. So that makes it a clinically relevant endpoint. The other thing is that we do know that SVT is a pretty strong predictor for venous thromboembolism. With regard to safety outcomes, we had a primary outcome of major bleeding, and this was changed during the trial because as we started central adjudication, our chairman of the committee, which was multidisciplinary, Bernard Tardy, noticed that it was very difficult to use the regular ISTH criteria for the evaluation of obstetric bleeding. And therefore, this committee proposed a new classification system that included obstetric considerations, which was then endorsed by the scientific subcommittee of the ISTH. We used antepartum, early postpartum, and late postpartum major bleeding. And of course, secondary, we also looked at clinically relevant non-major bleeding and minor bleeding. These are the interventions I think it's important to take in. The intermediate dose low molecular weight heparin was the intervention. It was given once daily, and we weight adjusted during pregnancy. As you can see, the weight in kilograms is listed below, and once a patient crossed a category border like 70 kilograms or 100 kilograms, her dose of low molecular weight heparin would be increased. Whereas for the low dose, low molecular weight heparin arm, also given once daily, this was fixed from randomization, and we only used 1 kilogram cutoff of a 100 kilogram at booking, and then decided which dose was appropriate. And we didn't increase if, for instance, a 95 kilogram woman would go over 100. And this is roughly the prophylactic dose as is used for medical patients. We designed a study with an event-driven sample size, and we needed 29 primary outcome events. And the assumptions, I'm not going too deep into this, but we didn't have much to base our assumptions on. And you will soon find out that potentially this may have been over-enthusiastic from our sides. We expected an incidence of VTE of 4 to 5% in the low-dose, low molecular weight heparin group. And therefore, the expected sample size when we started was between 859 to 1,074. And of course, we had a DSMB. The populations are important. We, of course, used the intention to treat principle where we did a primary efficacy analysis in the ITT population. We had a safety population that included all women who received at least 1 dose of allocated study treatment. And we also a priori defined a per protocol population. And these consisted of women without major protocol deviations, a self-reported adherence of 80% or more, and who received at least 1 dose of allocated study treatment. And this is the study flow diagram. We stopped the study after having randomized 1,110 women as proposed by our DSMB. The allocation was equal in both sites. As you can see, we had a very low number of loss to follow-up or withdrawal of informed consent. And you can see in the lower columns the intention to treat population consisting of all randomized women, the safety population a bit smaller, and importantly also the per protocol population, those women as I've just described, 481 and 491. And now we come to the results. These are the baseline characteristics, only a selection, of course, for this tool, but you can all find them all in the Lancet paper. The mean age was 32, the median body mass index 25, and we were able to randomize women at a median gestational age of a little bit over 9 weeks. The median time since previous VTE was a bit over 5 years, and a few of the women had a history of 2 or more episodes of VTE. And this is also important because we didn't want to jeopardize the safety of women. We allowed the use of low molecular weight heparin prior to randomization, and this was done in 48 and 45% of the women. And these are the results. As you can see here, this is the primary outcome of venous thromboembolism, and you can see that the relative risk was 0.69, which was not statistically significant. And the absolute numbers of symptomatic VTE up to 6 weeks were 2% in the intermediate dose low molecular weight heparin group and 2.9% in the low dose group. If we then move to this column with major bleeding, the primary safety outcome, you can see the bleeding rates during the entire study period that are listed here, 4.4 versus 3.8%, which was a relative risk of 1.16, which also was not not statistically significant. Now, if we then go and to that a priori defined endpoint where we also included superficial vein thrombosis, then you can see that the relative risk was 0.45, which was also statistically significant. And as you can see here, the absolute rates were 2.3 and 5.2%. If we look at the components of the efficacy up to 6 weeks postpartum, there were some very interesting findings. As you can see here with the colors, pulmonary embolism in blue, you can see that for the primary endpoint, and this component of pulmonary embolism was a priori defined secondary outcome, you see that the risk was 0.2% in the intermediate dose low molecular weight heparin and 1.6% in the low dose group, leaving a relative risk of 0.11, which was statistically significant. If we then also add the superficial vein thrombosis to the equation, then you can see that the relative risk is 0.23, also statistically significant. So when we got these results, we were slightly puzzled because it was a negative study, but we also did see some very interesting findings that are clinically relevant, and we were a little bit sorry that our event rate was a bit lower than we had anticipated. If we look at the safety outcome a little bit in more detail, you can see the major bleeding rates I've already mentioned. But if you look at the distribution between antepartum, early postpartum, or late postpartum, then you don't really see a signal of a differential effect according to the stage of pregnancy or postpartum period. But if you look at when we looked at the Kaplan-Meier curve, and we should realize that this is a little bit complicated because the Kaplan-Meier curve starts when we randomize women at a median gestational age of 9 weeks. And what you can appreciate here is that the lines actually really are very, very similar, both for the efficacy as for the safety outcome. And they start to diverge somewhere after 210 days. And this is approximately the time of delivery. So this prompted us to look at the differences between the postpartum and the antepartum versus the postpartum period. And here, this was a post hoc analysis that we didn't plan a priori. And interestingly, regardless of whether we looked at our primary endpoint or included SVT, you can see that antepartum in these two columns, there is no numerical difference between the two doses. But if you look, as the Kaplan-Meier curve suggested, at the postpartum data, then you can see that for the primary outcome, the risk was 1.1 versus 2%. And if you I think this is a typo, sorry, but if you look at the SVT, then the difference is more striking. And therefore, we noticed that the intermediate dose low molecular weight heparin really appears more efficacious with 1 versus 7 pulmonary emboli, 5 versus 22 superficial vein thrombosis. The strengths and the limitations, of course, need to be mentioned. I think I'm very proud, together with all my colleagues, that we were able to do a large thrombosis prophylaxis, RCT, in pregnant women with a history of VTE. And we should be reminded that only 2 very, very small pilot studies had been performed thus far, of 16, so 16, and 40 patients each. We do have quite some observational evidence studies of low molecular weight heparin in pregnancy, but we never know how consecutive and how well collected the data are. And what, of course, we did in this trial is we carefully documented the efficacy and adverse events. And we also had a central adjudication committee that was blinded for treatment allocation. We had a low rate of loss to follow-up. And because it became a very international study with a lot of centers, there was pragmatic low molecular weight heparin choice. We think that the findings are generalizable to many jurisdictions. But of course, we had limitations. The open label design may also lead to diagnostic suspicion bias. We had quite a few protocol violations that were mainly variations in peripartum strategies. And that was on the physician side. but also on the patient sides, there were quite some early discontinuations of low molecular weight heparin use postpartum. As I had already mentioned, we had an optimistic assumption in the relative risk reduction of 65%, so we were underpowered for what we observed. And at the end of all the adjudication efforts, we ended up with 27 instead of the 29 adjudicated events. So our conclusions of the high-low study are that in pregnant women with a history of VTE, weight-adjusted intermediate dose low molecular weight heparin did not reduce the risk of the primary outcome of VTE compared to fixed low-dose low molecular weight heparin. The absolute risks of VTE during pregnancy or up to 6 weeks postpartum was 2% and 2.9% despite low molecular weight heparin prophylaxis. And I really think that these data confirm the failures that had been published in some but not all cohort studies. And there was no difference in on-treatment major bleeding or other types of bleeding. I think that we can also conclude that of those randomized women, intermediate dose low molecular weight heparin showed a lower risk of pulmonary embolism, of superficial thrombophlebitis, or of VTE or superficial thrombophlebitis. And most of the benefit, or maybe all of the benefit, was observed in the postpartum period. I also share with you the intention to treat versus the per protocol analysis. And as I said, the per protocol analysis excluded women with a lot with major protocol violations. And you can see the Kaplan-Meier curves here, where you can see that the difference is a bit more pronounced, but you can also appreciate from the relative risks that still this per protocol analysis is also not statistically significant. But I should say we get a little bit closer to our, let's say, assumed relative risk reduction in the absence of data when we designed the study. And if you look at the major bleeding, I think you can also appreciate that there are differences also a little bit in antepartum bleeding. Although, again, this relative risk was modest, 1.12, and also not statistically significant. So how will the high-low study affect the guidelines? Well, as I said, I was part of the 2018 ASH guidelines and also part of that agenda point that I previously mentioned. But what is recommended at present? Interestingly, and I think this is quite I hadn't expected this. Our hypothesis clearly was that intermediate dose would be better. But this is what the recommendations are in the ASH guidelines. For pregnant women who require prophylaxis, the panel suggests against intermediate dose low molecular weight heparin prophylaxis during the antepartum period. And the panel suggests either standard or intermediate dose low molecular weight heparin prophylaxis during the postpartum period. And these are conditional recommendations based on evidence, and they have with low quality evidence, so they have a very low certainty. And as you can see, these are the remarks. Very low certainty evidence suggesting an unclear net health benefit for using intermediate dosing, but difficult to make significant conclusions given the limitations in the evidence. And I think that a high-low study really provides a lot more evidence, but of course I am totally academically biased, and I'm really looking forward to what the panel will do to these recommendations and how the strengths of the recommendations may change. But clearly, the standard dose, the low dose, antepartum minimizes the risks of bleeding, but more importantly, I think facilitates the access to epidurals. So I think this is a summary slide of the impact. Antepartum low dose, low molecular weight heparin is appropriate. It facilitates access to neuraxial anesthesia, and of course it's cheaper than a higher dose. Whereas postpartum, the intermediate dose, low molecular weight heparin appears to be more efficacious at no cost of bleeding. But as this was a post hoc analysis, ideally, it should be confirmed in a new RCT. I think one of the other things and takeaways that I would like to present today is that we have shown that thrombosis prophylaxis RCTs in pregnancy can and must be done. And I'm just going to show you a little bit of the stamina that we needed to get this study finalized. This is a progress slide of 7 years ago. And the sponsor when we started was AMC, my employer at that time. And we had started off with an unrestricted grant provided by GSK and later taken over by Aspen. And you can see the first inclusion in April 2013 until October 2015. So 2.5 years into this was the number of study sites, and 2.5 years into the study, you can see that we were only just around 110 patients, about 10% of our, let's say, what we now know was our recruited sample size. So what could happen? What could have happened here? We could have stopped. We could have said, well, it's impossible. We will publish the results right now. Well, we wouldn't have had that impact, of course, and we did have the stamina and it took us 7.5 years. And what got us here, I think, is important to mention, is that at some point in time, early onwards in the trial, the French network of VTE research got interested, and with Andrea Buchmuller was able to get a grant from the French Ministry of Health. And with that large national French network, it was possible to recruit a lot more centers, but also to raise the quality of the study, because the French had the DSMB and organized all the central adjudication events. And later on, in Ireland, Professor Fionnuala Nienley, who had at that time also started a VTE network in Ireland, it took some time, but she also got an Irish grant. And that is how our, let's say, seeding money got us further, because the French were now, how do you say that? The French network was now paid by the Ministry of Health, and the same was true for Ireland. And we got a lot of centers, and you can see here what happened. And our recruitment rate has been very steady till from that time onwards. And that is a reason. I know this is a Can Factor event, and I have spoken about networks in a Can Factor event in 2020. And I think the Invent VTE network, that was really the international Can Factor example, where Can Factor is an example, I think now has 10 members. We recently added China to our investigator Invent VTE network. And I think, although not all countries were able to recruit, many of the countries were. And this, I think, has been crucial for our high-low study. And that is why I want to thank all these investigators. And you can see indeed from the recruitments that the Netherlands, who just had 2.5 years more time, but then were easily followed by the much larger country of France, Ireland, and as you can see, going onwards until Russia, that participated quite late, and same for Denmark. I think if Denmark would have been there earlier, they would have recruited like crazy. Of course, we need to thank a lot of people that are on this list, but most and foremost, the women who were allowing us to randomize them into the high-low study. And I think this right now is my final slide, and I hope that I have inspired you, because I do think that we need more high-low studies, high-low 2, high-low 3, because there is so much more on the list, and I'm really happy to share my thoughts about that also, let's say, outside this webinar, and hopefully to get some people interested to do this. Thank you so much for your attention, and I'm really happy to take questions.
Thank you so much, Professor Middeldorp, for this really instructive talk. So we will start with the question period. Certainly, there's a lot of congratulations in the Q&A, and I think that's worth mentioning. I think it's quite a feat to randomize over 1,000 women in an RCT. So thank you for sharing your results with us. The first question, which is a question that I also had from Susan Kahn. Congratulations, Saskia, on this landmark trial. I know the numbers who had VTE recurrence in each group were small, but do you have any descriptive info on these women? Do we know if they had higher BMIs or the nature of their prior VTE?
Yeah, so great question. We do, in the supplement of the Lancet, we do show the subgroup results. And indeed, the numbers were quite low. Well, it depends on what you call low, but we couldn't really identify a specific group of women. So we looked at body weight in various ways, not only BMI, but body weight. And we even looked in 10 kilograms categories to just see what was going on. What you do see clearly is, for instance, that women who are heavier, they seem to have a slightly higher risk, but the difference between the two study arms is very similar. And likewise for known thrombophilia, those women, I think, have the highest risk, but there is no differential effect of the intervention of intermediate dose low molecular weight heparin.
Great, thank you. A question from Rita Selby. Saskia, always amazing to learn from you. My question was about the inclusion criteria, women with unprovoked VTE and those with provoked VTE via a hormonal risk factor. They were combined. They have different risk profiles. Why did you decide to combine these two categories?
So basically, we decided to have a pragmatic trial that was similar to a clinical practice. And so we started at whether or not they needed antepartum prophylaxis. And of course, we also looked at this subgroup to see if unprovoked, for instance, women with a history of unprovoked VTE had a much higher risk than women with a hormonal provoking first VTE. But, and this is all in the supplement, so I really invite everyone to also download that one. Indeed, there may be a little bit of a difference, but we didn't really see that. And we should not forget that we only had 27 adjudicated events. So our study really was not designed to look into this. But I hope, Rita, that I have explained well to you why we simply chose this. And I must also admit, and I think this is the reality of doing trials, that there were very few, but there were a few women that actually were not eligible at the end of the day. And we have of course considered getting them out of the ITT. And so those were, for instance, was a woman with a major provoking risk factor. But we decided not to get into any discussions about the ITT principle, and we left them all in. But clearly, this doesn't really change the results.
Great, perfect, thank you. A question about other safety outcomes. Were there any other side effects in the women in the higher versus lower dose, like osteoporotic fractures?
So this would have been a SUSAR or a severe adverse events, and they were not reported. And personally, I think it's, of course, if you look at very rare safety outcomes, then a trial, even if it's well sized, is not good to look at safety. And then we would need large observational studies. I think that this is also Canadian research by Mark Roger. This whole fear about fractures comes from unfractionated heparin and a small observational study that had, I think, 2% or slightly over 2% of osteoporotic fractures. But Mark Roger and his colleagues did a study with scans, DEXA scans, showing that the bone loss was very similar to women who were treated with dalteparin as to other pregnant women. So it probably, I don't know if it's true, but I'm not worried about it for low molecular weight heparin.
Great, excellent. Speaking of Mark Roger, he is in the chat. Congratulations, Dr. Middeldorp, huge accomplishment. And this is a question I think everyone has. Can you share how the results have changed your personal practice?
Yes, so I can tell you, then I have to go back because it's my third academic center that I'm working. So we started off in Amsterdam when I was, let's say, very junior. we had the idea that it was not a problem to bleed, and we didn't care about costs. So together with the centers in Groningen and Maastricht, which are really as far as you can get in the Netherlands from Amsterdam, we all used therapeutic dose low molecular weight heparin as a prophylaxis. And when we designed, and Mark knows this, of course, that's why he's asking, when we designed the study, I would really like to have the therapeutic dose, because we had seen nil recurrences in an observational study. Whereas when I was in Leiden, I did see almost up to 8% in that high risk category. So I would have loved, and I think from a trialist perspective, to have a separation between the two interventions as large as possible. So therapeutic dose versus prophylactic dose. Now, this was something that I couldn't get anyone, particularly people like Mark or in the North American continent, where neuraxial anesthesia is really, really important to get a baby. I couldn't get anyone enthusiastic. So I already changed my practice when we started with high-low in Amsterdam. So what we did at that time, we said, okay, everyone who's not participating will get the low dose. Because so we changed practice at that time. Now I'm in Nijmegen. And what we do is we give low dose prophylaxis antepartum and intermediate dose postpartum. Of course, this is not what we tried. We didn't formally assess this in the high-low study, but we will definitely get more sub-studies, which are basically more observational type analyses from high-low to help us learn more from the study.
Perfect. So it has changed your practice for the postpartum.
Yes. Doing the trial has changed my practice, but having had the result, it also has changed my practice.
Wonderful. Okay, thank you. Question from Joel Ray in Toronto. What was the rate of cesarean section in the trial?
Ooh, I don't know that by heart, to be honest. The data are there, but I don't think they are in the main paper, but we are very close to having an neuraxial anesthesia paper accepted, and those rates will be there. And I don't think this is appropriate for me to now go look into my computer to answer this question. Perfect. But the data are there and they will be shared.
Perfect.
Maybe if I can just say one more thing about this, for this neuraxial anesthesia which basically is an observational study within the trial. We did see differences between the high and the low dose if we looked at the time interval. So the eligibility was better in the low dose group. So I think that is also a very important reason to really implement what we have found in the study antepartum. But the other thing which was really interesting is the big differences between the countries in terms of rates of neuraxial anesthesia. There are massive changes. And I think that sort of really helps explain the different interpretation or the different fears, I should say, of let's say, common practices that we now can also substantiate with trial data.
Right. And I wonder if, neuraxial anesthesia eligibility doesn't necessarily, or rather, who got neuraxial anesthesia doesn't necessarily represent eligibility, and patient's choice has to be count. Yeah. So difficult question to answer for sure. So Leslie Skeet, there's so many congratulations in the chat box, Professor Middeldorp. So Leslie Skeet, congratulations. So she comments on the fact that the CIHR funded Prep and Go study, which you're a part of, is a new observational study starting that evaluates anticoagulant strategies around delivery and postpartum. So 2 questions from Leslie. How easy or challenging were putting together the adjudication packages using the newly proposed definitions where detailed delivery information is needed?
So this was feasible. Of course, it's a lot of work. And I do think, to be quite honest, that we can that let's say the classification system that was proposed has raised not so much discussion as I would have anticipated. So I do think there is room for, let's say, fine-tuning and perhaps a Delphi exercise or something to see if you can refine that a little bit. But it was very feasible to get the adjudication packages together. But we should also notice, of course, that this was a trial, so that all the centers and all the women who were participating in the trial, there was, I think, a better follow-up than when you don't do a prospective study. But the registry clearly should be prospective. And I do think it's very, very important. And actually, I would love to do a trial on peripartum strategies, knowing how even better than a registry, because of all the confounding that you would introduce that you cannot capture in a registry. But it will really, I mean, we need people like Leslie to do those trials.
For sure. And she also asked, can we get confirmatory high quality data postpartum anticoagulation dosing using this observational method?
Yes, I do think so. If you are absolutely certain that your loss to follow-up rate is well, so if you really register everyone, let's say early on, I think that is necessary. And that is what was not happening in all those registries that we had on low molecular weight heparin in the past. And the other thing that was one of the reviewers' comments in the process of getting high-low published, and that is the fact that we had so many early discontinuations. So I think high-low has a wealth of data of people to dig into to see what was happening there that we don't have. I don't have them yet. So what was happening? Why did these women stop? Were there any predictors of women who decided that they were not afraid and they were just fed up with the injections? I'm really curious. And I think one of the reviewers mentioned, and I think we even mentioned it at the end, thanks to the reviewer, that getting more insight into why women adhere or do not adhere, I think could also be a very good strategy, because we did see a difference between the per protocol and the ITT. And if we can get it to lower numbers by getting the adherence, increasing the adherence to our protocols, that I think is also something that probably wouldn't need a large trial. Maybe a trial, but not as large as this one.
Right. Okay, perfect. A question from Aurélien Deluc in Ottawa. Congratulations on this achievement. Were women who had a postpartum VTE as prior events eligible in the trial?
Yes.
Yes. And
yes.
If yes, would you do low dose antepartum and high dose postpartum? Yes.
Yes.
This was already answered. Yeah. Sorry about that. Okay, a question from Vicky Taglakis. Thank you very much for this excellent and much needed study. We now have data we can provide our patients with regard to the expected rates of VTE and bleeding, which is wonderful. I'm curious to know how many dosing changes were needed per patient on average in the intermediate dose group.
A great question, but I don't have the answer. I mean, we do have the answers, but we haven't done the analysis in detail.
Perfect. Great. Are there any women in whom you would use therapeutic dose low molecular weight heparin prophylaxis now?
The women who are on continuous anticoagulation outside of pregnancy.
Perfect. I'm just trying to see if there's anything that's unanswered. Oh, another question from Mark Roger. I think this relates to an earlier comment by Susan Kahn. Any early data or thoughts on the predictors of postpartum events to target the selection of low versus intermediates?
Well, we couldn't get it from, let's say, the data that we have now looked at. And that is all very categorical. So these are all the predictors, yes, no, that we know. And I don't think our numbers will enable us to use some clever types of propensity or whatever. So I'm afraid really our trial doesn't really allow us to look into this. Well, we can look into it, but we cannot draw any firm conclusions.
Perfect. And maybe I'll ask you one last question. You said that now your practice has been to give intermediate dose low molecular weight heparin in your patients. Do you still take into account the risk of bleeding? And are there still factors clinically that would make you prefer the prophylactic standard dose in your patients?
So I think if there's massive problems with vaginal delivery or C-sections with, of course, a woman where hemostasis is not yet adequate, I would not immediately start with intermediate dose.
Perfect. So a gradual.
So I think, yeah, right. I mean, you can see how well the low dose is being tolerated. But this is not something that, I mean, it does occur. Obviously, we always say restart 12 to 24 hours, provided hemostasis is adequate. I mean, then this is up to the gynecologists to judge that generally. And maybe if you allow me, as I said, so the definition of what is high and what is low. I mean, I don't mean the doses right now, but the absolute risks. So if we see a 2 to 3% risk that we saw in the study arms, then I don't think it's really low. And I'm just curious. I mean, of course, this is difficult to interact. But if I would be in a room with my colleagues, my Canadian colleagues, I would like to see some hands to see, do you really think that's low? I mean, it's much higher than let's say thresholds of risk that we allow for non-pregnant patients. And so that is still puzzling me sometimes. So yes, we know now it's 2 to 3%, but I don't think it's low. And if you look at, for instance, the threshold that we decided upon in the ASH VTE guidelines, there was a small poll done by the panelists, and it was around 2%, 3% for antepartum prophylaxis. And look at where we're now. We are still at 2 to 3% with prophylaxis.
Yes, very interesting. That's definitely thought-provoking to think that we're at the same target we were prior to deciding on initiating prophylaxis.
Yeah, and perhaps if we would do therapeutic, perhaps, but
we don't yet know the answer to
well,
that.
we need another 8 years and a lot of courage, I think, to do that.
Perhaps Hilo too will be looking at this question. So Professor Middeldorp, thank you so much for this wonderful talk. And thank you for all the participants. So just a final reminder that the recordings are available online. Please don't forget to complete the seminar evaluation. They're very helpful to us in order to plan further seminars. And please stay tuned for details about the next seminar that will take place in December. Professor Middeldorp, thank you very much, and have a wonderful day, everyone.
Was my pleasure. Thanks, everyone. Looking forward to seeing you in real life.